All right. Well, good morning, everyone. Thank you so much for joining us. My name is Danae Aber. I'm the Executive Director of the Louisiana Rural Health Association. LRHA is happy to host this virtual vendor showcase for the Rural Health Transformation Program in partnership with the Louisiana Department of Health Office of Rural Health Transformation and Sustainability. It's quite the mouthful. This event is being recorded. It will be available in the webinar recordings page of our website. Along with that recording, we'll also include a copy of the slides, as well as a database of all of the vendors who applied to be part of the showcase today, including those who are here to present and those that are not here to present today. Anyone who applied will be in that database, and that will be linked on our website. And I will drop a link to the relevant page in the chat here momentarily. Um, so I'm just going to go through a couple of quick housekeeping items before we jump into the agenda. So here's our agenda for today. After I kind of go through our housekeeping stuff, I'm going to pass it off to LDH to talk about value-based care challenges in rural Louisiana and present an overview of the recently released Rural Health Transformation Fund Notice of Funding Opportunity. After that brief presentation, we'll hear from each of our vendors before moving into a Q&A session. So all of your lines should have been muted automatically when you joined. Please do remain on mute to prevent background noise throughout the session. Please feel free to enter any questions into the Q&A box throughout the presentations today. And when we get to the Q&A portion of the agenda, we'll answer as many of those as we can. After the webinar, a survey should automatically open in your internet browser. We do ask that you please complete that survey. It helps us to continue to improve our future events and identify future education topics that may be of value to our members. And so with that, I would like to welcome Eli Brodsky, the Deputy Director of the LDH Office of Rural Health Transformation and Sustainability. Eli, I pass the floor to you.
Thank you so much, Danae. And before we get started, a small technical issue, Danae. I really need to ask you about the second slide in this presentation. I need to adjust it. So do you want me to share my screen instead?
You can let me give you access to do that. All right, see if you are able to share.
All right, looks like I can. All right, thank you so much. Tell me if you can see my screen.
Yes.
All right, thank you. This is the slide that I needed small changes on. But welcome everyone to this webinar. Really excited to see you all join today. My name is Eli Brodsky. I'm the Deputy Director of the Office of Rural Health Transformation and Sustainability here at Louisiana Department of Health. And I wanted to share with you a little more information about the Notice of Funding Opportunity that I think some of our presenters today will align well with. So before we get started, I wanted to make sure that it's clear that this project is supported by the Centers for Medicaid and Medicaid Services, CMS, of the U.S. Department of Health and Human Services, or HHS, as part of a financial assistance award totaling $208,374,447.57, with 100% funded by CMS HHS. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by CMS HHS or the U.S. government. So I wanted to briefly talk to you about the Notice of Funding Opportunity Design, data availability that I think can inform some of your applications, and then strategic alignment with other LDH initiatives around rural health transformation. So the Notice of Funding Opportunity that we already published on our website is available for questions and then applications. And we're really hoping to hear from providers of any types that are currently licensed in Louisiana. And so we want to explain a little bit what went into the design of this Notice of Funding Opportunity. What do we see as a top priority to address in terms of some of the challenges that our rural patients are facing? and how we're thinking to go about this direction in the next few years. So this alternative payment model strategy seeks to address disparities in rural health outcomes in Louisiana by addressing the financial sustainability of services offered with a shrinking population and greater challenges in chronic disease and episodic costly services. So the alternative payment models improve quality and total cost of care by aligning financial incentives with patient outcomes and rewarding providers for delivering coordinated, preventive, and efficient care. And what we are trying specifically to focus on are rural provider participation in value-based care in general, reducing avoidable utilization through coordinated primary and preventive care, improving outcomes for chronic disease and priority populations, and increase access to care close to home. So in total, we have $30 million for year one. This is amount that we would like to contract and spend by the end of federal fiscal year or the budget year two, which starts in October of this year. Some of the things that we are aware of in terms of why this is needed is that rural parishes have about a 5 percentage points higher PMPY than urban parishes. So that is per member per year total cost of care. Rural parishes also have a 3 percentage points higher incidence of individuals with one or more chronic conditions. Despite this, rural emergency department and inpatient utilization per capita is lower than in urban areas, indicating potential physical access issues. And some of those challenges include psychiatric, cardiovascular, skeletal, gastrointestinal, and pulmonary conditions that are leading contributors to total rural Medicaid spend. So because of these factors, we are designing this initial set of pilots to improve quality and outcomes, primarily for Medicaid patients by expanding proactive primary care, chronic disease management, behavioral health, substance use integration, and health-related social needs support, as well as care coordination. Number two, reducing avoidable utilization and total cost of care over time by helping providers manage patient panels earlier, close care gaps, and prevent avoidable ED visits, admissions, readmissions, and duplicative care. Reduce provider burden by creating a clear, consistent model across MCOs, payment arrangements, and reporting expectations. Four, supporting providers at different starting points by allowing flexibility in implementation timelines, partners, infrastructure, and degree of value-based care readiness, and ultimately creating a glide path towards shared savings or risk over time by building common capabilities, measures, attribution, and performance expectations. So what we are doing in the first year is looking for pilot-ready projects, but projects that have sufficient potential impact so that more providers can join the next steps towards risk sharing. And a big part of that is making sure that you have the infrastructure in place to be able to address both high cost, the drivers of cost, and significant populations that are currently on Medicaid in rural areas. And let me talk a little bit more about eligibility and how we're thinking about making sure that the most number of providers can actually participate as well as benefit from this initiative. So first of all, we want to make sure that providers are at the center of this funding opportunity. What you're going to hear from today in terms of vendors that provide aspects of enabling technology or capabilities are really partners in your application for this NOFO. So the eligible applicants are limited to Medicaid enrolled providers and applicant teams that include Medicaid enrolled providers, such as provider coalitions, independent practice associations, rural hospital-led partnerships, FQHCs and RHCs, as well as other provider-led collaboratives that include Louisiana Medicaid enrolled providers like ACOs or CINs, clinically integrated networks. So the objective here is to prioritize funding directly to providers, avoiding vendors that do not have clear customers or market demand, and facilitate sufficient scale in a potential patient panel to eventually enable shared savings or two-sided risk. As you know, those were some of the barriers that many of you shared with us, and we want to make sure that we are prioritizing those that can work together to address significant challenges in rural populations. Eligible use of funds are really divided into two buckets. One bucket is practice transformation, and the second bucket are specific types of payments for performance and shared risk. So first of all, the practice transformation payments. This includes infrastructure, staffing, workflows, data capabilities, and tools needed to implement evidence-backed clinical activities and the care delivery model. This is to overcome barriers that have data, reporting, infrastructure, or specific staff that you currently don't have. And for those specific types of challenges, we don't envision ongoing payments. We envision kind of like a one-time investment into building up those capabilities until you're able to address a specific challenge. And then the second bucket is divided into two different types of opportunities. One is in lieu of services, ILOS-style clinical activities, and the quality process and total cost of care type payments. So for ILOS, we're talking about activities that are not reimbursed by Medicaid for the target rural Medicaid population. This might include activities that don't have a billing code associated with it, or capabilities and services that don't exist specifically in rural areas. And for total cost of care and quality, we're looking for payments tied to reporting, improvement, or achievement of quality or process expectations, while monitoring total cost of chronic disease or total cost of care. And these payments are going to be tied to reducing total cost of care while meeting quality or process expectations. Now, we know from surveys that many of you don't have access to timely and accurate data on cost of chronic care, on total cost of care, and even prevalence of specific chronic conditions. So we wanted to make sure that we are addressing the concerns that we heard from you. About 40% cited limited analytics and reporting infrastructure, and then 18% cited limited claims and utilization data access. And so what we understand is that there is a need for patient attribution visibility, provider level quality, and TCOC metrics, as well as care gap identification. So we are looking at vendors who are looking at specific enablement capabilities for providers to address those APM needs. But we're also looking as a state to pool our resources and make sure that data is becoming more accessible and available for at the practice level utilization by rural providers. What we want to make sure is that it's clear that these types of funding opportunities are not overlapping with current and existing Medicaid opportunities that you might already be participating with. Which means that we are going to be asking for specific information from those providers that are applying for this funding opportunity on what other value-based care contracts and programs you're participating in, what types of opportunities exist, and what kinds of payments you are receiving. We're also focused on one-time catalyzing investments so that we can see the outcomes for those providers who currently do not participate at all in value-based arrangements, or are not engaged in maximizing the opportunities that they have based on existing contracts that they do have. Now, with that, I want to mention that we will have a number of data sources becoming available throughout the year. We're currently evaluating some of those sources and how much of it can be made readily available, and that will be based on your application. So if you are planning to apply for the SNOFO, or you have partners that you're working with that are planning to apply to the NOFO, we encourage you to reach out to us, submit your questions, and complete the application so that you can get access to detailed data from Medicaid claims. I'll briefly review some of that data so that you understand what kinds of data might be available for you in the areas that you provide services. So first of all, I mentioned that rural parishes have a 5% higher per member per year PMPY than urban, but lower utilization. So what that means is, on average, per member per year costs in rural areas are about $261 more than urban areas, and that is about 4.8%. For emergency department admissions per 1,000 members, about 20.9 is the difference. So 20.9 admissions per 1,000 higher in rural areas than in urban areas. For avoidable ED admissions per 1,000, it's about 0.8 lower for rural versus urban. Inpatient admissions per 1,000, it's about 10.3 lower. 14-day readmission per 1,000 is 1.3 lower. 30-day readmissions per 1,000 is about 1.9 readmissions per 1,000 lower in rural versus urban. So as you can see, there's some discrepancy in what typically drives total cost of care and utilization, and we are still exploring on what might be the driver for that. In terms of chronic disease burden, we thought of this in two ways. First of all, we saw that there are top 5 prevalence versus the cost. So on the prevalence side, we see that CNS, GI, diabetes, skin, and skeletal conditions are driving that prevalence. And for the cost, hematological, obesity, genital, infectious disease, and pulmonary, and all of those seem to be higher. So you can see that the top chronic conditions are CNS and GI in terms of prevalence, about 20% higher in rural versus urban. And on the chronic condition cost, the top ones are hematological and obesity, about 8.2% higher for hematological and 6.1% for obesity. You can see some of those gaps align, and I think what is helpful is to see, this chart that aligns both of these measures together. So on the y-axis here, you have PMPY in US dollars, and on the x-axis, you have percentages by prevalence. All of this is for rural patients. What you can see here as an example is this outlier on psychiatric. Psychiatric affects a certain, so 27% approximately prevalence in rural areas, and it is at a cost of between $10,000 and $15,000 per member per year. Versus cancer, the prevalence is fairly low, approximately 1%, but the cost is very high, 45%. And then the bubble size represents relative cost burden across rural population. So this is the total cost for rural population, not PMPY. So you can see that the rural costs are driven more by prevalence than cost of conditions. 2 conditions contribute most to the rural cost burden, which is cardiovascular, about 20% prevalence, psychiatric, which is 27% prevalence, despite moderate PMPY, between 12 and 16,000 PMPY. The highest PMPY conditions, cancer, hematological, cerebrovascular, and infectious, between 38,000 and 45,000 are rare, about 2% prevalence, and therefore depicted as smaller bubbles. Per member cost falls as prevalence rises, and follow-up investigation is needed into key drivers of observed PMPY and prevalence trends. And that's the work that our team is doing. And we are happy to work together with the providers applying to address some of these prevalent conditions to support your proposals and your interventions. Already, as mentioned, there's a difference on Medicaid population and PMPY by parish. So on the left side, you can see the map of Louisiana where the darker blue is the high Medicaid population in actual numbers. And on the right side, you can see PMPY where the dark is the highest PMPY in parishes. So in terms of the numbers of Medicaid patients living in parishes that are urban, those are the darker blue ones. And then PMPY by parish, you can see those are actually rural parishes primarily. So what we expect to see are some interventions that affect the correct number of patients in primarily rural parishes. And as you know, we have published our rural definition. So if you have any questions about that definition, we will be able to share that link with you so you have clear guidance on that as well. As I mentioned, and I'll finish here, most of the challenges that we are trying to address in this first year are driven by survey responses from those organizations that submitted information and questions when we put out this APM survey. We had independent rural health clinics, rural hospitals, and critical access hospitals, as well as FQHCs, independent primary care practices, and provider-based RHCs. We will continue to monitor responses to this survey. As Danae mentioned, these surveys help improve our work, and that is true for both LRHA as well as LDH, and specifically the RHTP team. So if you have any questions, the questions are now open under this funding opportunity on our website, and the survey should still have been emailed to all of you. And if you would like to share your insights, questions, or any specific direction that you would like us to consider for year 2, we welcome you to fill out that survey. I will be on this webinar, again, paying attention to some of these presentations as well. If there are any questions specifically to me about this presentation, feel free to share them as well, and we will consider including responses to those questions in our future webinars and making those publicly available on our website. Thank you.
All right, thank you so much, Eli. We do have just a couple minutes before we were scheduled to move into the vendor showcase. You do have 2 questions in the chat. Do you want to do those right now, or do you want to wait till the end?
Yeah, I can definitely try.
Okay, so the first one is, and this was on one of your earlier slides, how is avoidable utilization defined?
Avoidable utilization is defined using the ICD-10 codes that are, there's an algorithm that basically says if it is urgent, if it is preventable, and if it is avoidable. So we follow that algorithm. The analysis was done by our Medicaid business analytics team. So if you have further questions, I'm happy to provide the details of that algorithm.
All right. The next one is, what would be the billing process if there's no code associated with the activity?
So at the moment, you have 2 options. You have codes that are currently not reimbursed under Medicaid. That's one way to do it. So you essentially still put the code on the claim goes through, and then Medicaid would typically not reimburse you, but we will, on aggregate, review, validate that data, and provide reimbursement. And all of that would be spelled out in the contracting timeline after the NOFO. And then the second option is ILOS. So ILOS services would be, again, specific service that you propose. For example, care coordination. That would be billed in lieu of a specific service that the patient typically receives. That would be based on historic data. Again, during contracting, we can discuss the specific way to document those services provided and how that aligns with the claim submitted to Medicaid through MCOs.
All right. And the last one we have here, oh, we just had another one pop in. So the CMS Merit-Based Incentive Program, or MIPS, now has a medical dental integration measure that considers the impact of oral inflammation and infection on systemic conditions like diabetes and heart disease. Should rural clinics consider this in their APM modeling?
Since we already pointed out diabetes and other chronic conditions being prevalent and costly for rural parishes, we do see this as a high priority, but the specific proposals could be reviewed with some follow-up discussions after or during the NOFO period.
Okay. Um, for the incentive payments, does the state have a settlement methodology, or are you asking to propose an incentive program?
We are asking to propose an incentive program. It should be a pilot for year one. And as we see the effectiveness of the pilot to improve quality and address the total cost of care, we will have follow-up conversations with the broader LDH to determine whether it has merit to continue moving forward into years 2 and 3. But we are looking for pilots with a potential for multi-year projects that are addressing quality and total cost of care.
All right, thank you so much. That's the last question that we have, and we are right on time. So if any other questions come up on Eli's presentation, feel free to put those in the Q&A box, and we'll circle back at the end when we get to the Q&A session. So let me see if I can share my screen again. All right, let's see. So hopefully you can see my screen. So we will move into our vendor showcase. So each presenter will have 3 minutes to give a quick pitch of their value-based care solution or service. The goal of these presentations is to give you an idea of services, tools, and organizations that may be valuable partners for you as a rural clinic or hospital. If you'd like any additional information about any of these organizations, their contact information will be included on their slide. Also, as I mentioned, all of these organizations, along with several others, will be included in a vendor database that we're going to link on our website following today's session. So just a quick disclaimer that neither LRHA nor LDH directly endorse any vendors, companies, tools, or solutions. We just want to make clear that this is just a slate of potential organizations that we think may be valuable partners for you, but we do not endorse any specific organization or tool. So with that, I will welcome our first presenter, Christopher Neal from Azara Health.
Thanks, Danae. Thanks, Eli. Can you hear me okay?
Yes.
Great. Well, thank you everybody for your time today. I see some familiar faces, and for those of you who don't know us, I'm happy to introduce Azara Healthcare. My name is Chris Neal. I'm the Vice President of National Accounts, and I think right now we're in a period where data is paramount to optimizing care delivery to those patients seen by the safety net with coordinated, preventive, and efficient care. And Azara's mission since day one has been to do just that. What we're bringing to the table is called Azara Drives. Drives is an application. It's a comprehensive BI pop health reporting and analytics solution that provides within the workflows of the provider organizations actionable data. Data that the staff can trust. It's often described as a coworker that can help guide the attention of your staff towards the areas that align with the overall goals and objectives of your organization. And that's one piece of the puzzle. The other piece is that it is a clinically integrated, centralized infrastructure, which means we're aggregating data, we're EHR agnostic, we're sorting and normalizing that data centrally so that network partners of ours can tell a story. And each of the participating health centers can tell a story. Identify best practices, share that across an entire network, respond to grant opportunities more seamlessly and easily. Identify shared patients, share data on shared patients, again, so that you can optimize that care delivery to the patient population across the board. Um, we have started since day one with that centralized infrastructure and realized there are other pieces to the puzzle as it relates to data and disparate data sources that we can integrate to provide a more comprehensive view into the care delivery to the patient population that can improve with avoidable ED visits in the form of HIE data for transitions of care, identifying utilization, using that as an alert, being able to reduce readmits, and having all the data to support the analytics and efficacy of your programs on that front. We also ingest payer data for value-based care reporting. So being able to integrate that where we can have the attribution files, identify matched versus unmatched members, bringing in care gaps files so we can reconcile the data that you have within your EHR with the data that the payers have so that you can be successful as it relates to your value-based care contracts. We've been honored to work in Louisiana since 2017 when we partnered with the Primary Care Association, and since then done a spectacular amount of work in laying a solid foundation with LPCACO, working with over 33 organizations, FQHCs, rural health centers. And I'm just excited about this opportunity because, while there's a lot of innovative stuff we can do in the future, we're shovel ready to do something really special on day one. So I'll stop there.
All right, thank you so much. Perfect timing. So I just want to confirm if someone can pop in the chat, are you seeing the slide and the presenter? I want to make sure I've got the view on correctly. Awesome. Okay, thank you so much. All right, because as the presenter, my view looks a little bit different, so I just want to make sure everybody can see everything. All right, so next up, we will have Chris Meehan from Bamboo Health.
Thanks, Danae. Chris Meehan, Bamboo Health, Vice President of Growth. At a core, understanding where your members and where your attributions are having care events is a core to controlling those costs. So Bamboo Health, we've developed and created and curated the nation's largest, most diverse care coordination network across all care settings, from the hospitals to post-acute to clinics, allowing organizations to understand when their members have care events across the continuum. In doubling down on that, we're really well positioned, not only from our care coordination, but we partner with the state of Louisiana to provide the controlled substance database into all providers' hands so that, your providers have access to the PDMP data in workflow. So what that means is there's a core problem in behavioral health, in care coordination. And I think behavioral health, the needs, and Eli kind of pointed out the psychiatric exposure, where over 25% of people have a behavioral health condition, and that total cost of care and controlling that total cost of care, those have run between 3 to 6x higher than those without. And at a core is access is broken. And the result is these rural parish members fall through the cracks, and it drives a disproportionate cost to controlling those costs. So Bamboo Bridge, we have a behavioral health care coordination service that combines both AI and human support to guide individuals to the next site of care. It works at these pivotal moments. So we have all the ADT data from the hospitals and post-acutes, and we have the controlled substance database where we have those pivotal care moments and understanding when those patients are at a very vulnerable moment during the patient's life cycle. In Bamboo Health, we offer the end-to-end care coordination service to identify the member, engage them, assess their needs, and match them to our curated network of behavioral health needs. we've seen this work. We partner, across, the states, and it's really been impactful to white glove these patients and have them show up for appointments in a situation in your rural parishes where you may not have all the services that the needs of that. We're excited about the work we're doing in Louisiana. I think we're well positioned to close these gaps and really drive some outcomes. So we appreciate the opportunity to work with you and happy to address any questions that you may have.
All right,
I think,
Garrett, you have 25 seconds left on the clock if you if you want to add anything else.
yeah, no, I think no, I think that's it.
All right, awesome. Thank you so much. Um, so we will move right along to Kevin Zhao with Carrot Health. You have the floor.
Hi, everybody. My name is Kevin Zhao, and one of the co-founders and CEO of Carrot Health. At Carrot Health, we provide a next-generation care coordination solution, which is specifically designed for rural hospitals and value-based care. We've been deployed in over 60 hospitals across 10 different states and have achieved some really strong outcomes. And we are very excited at the opportunity to bring these outcomes to Louisiana. So, with the rise of alternative payment models and their requisite performance incentives, providers today are now being faced with creating many programs across care coordination. This includes programs such as quality improvement, remote patient monitoring, chronic care management, transitions to care management, cancer care navigation, etc. So, what we do is we consolidate all these programs under one single technology-driven service. And this allows providers to avoid the problems of hiring multiple vendors, bring on large teams of staff to manage these vendors, and coordinating workflows through spreadsheets and brute force labor. And so with Carrot, all these programs are available with one single partner. We also create a local centralized workforce of medical assistants, nurses, pharmacists, et cetera, to operate these programs as an extension of each hospital's existing clinical teams. And our technology platform ensures that these workflows are as efficient as possible. So no redundancies in patient outreach across multiple programs. We've generated some really fantastic outcomes. In particular, over the last 1.5 years, we've deployed at the Rough Rider High Value Network in North Dakota, which comprises of over 20 hospitals. Over the 2025 calendar year, some of our highlights include greater than 50% quality gap closures and reduction in readmissions from 16.5% down to 5%. In addition, the just released 2025 Blue Cross Blue Shield data for the Rough Rider network in the state shows that as a direct result of utilizing Carrot Health, as a network as a whole, they satisfied 4 out of 5 total, network-wide quality measures for its commercial population compared to only 2 from the year before. And for its Medicaid population, there's some key highly weighted measures such as cancer screenings, preventive visits, controlling high blood pressure, and A1C control that had average improvements of over 20% relative to the prior year. So we want to bring these outcomes to Louisiana. Over the last month, we've already received LOIs from 8 hospitals and are already deploying in the likes of Allen Parish Community Healthcare and LaSalle General Hospital. And with RHCP funding, we intend to offer our service to as many hospitals as possible. After we deploy, we want to leverage our data collected by the system to create an AI orchestration layer that is specific to Louisiana patients. And this is important because one of the biggest problems with care coordination is that staff often spend over 90% of their time on spreadsheets and manual tracking and less than 10% of time on actual patient care. And with this AI orchestration layer, we can flip the script, automate a lot of manual work, and enable hospitals to massively increase scalability and throughput. So overall, our goal is to democratize care coordination and ensure that every hospital can provide better care, capture more revenue, and sustainably improve clinical performance. Thank you very much for your time.
All right, thank you so much. You guys are really good at this 3-minute timer thing. So I really appreciate everybody staying on time so we can get through a lot of content really quickly today. So thank you so much, Kevin. So we will now hear from Michael Poku at Equality Health.
Afternoon and good to be with everybody. I am Dr. Michael Poku. I'm a practicing primary care internist and I'm the Chief Clinical Officer for Equality Health. We are at our core unabashedly Medicaid focused, value-based care enabler and aggregator. And at the simplest level, we help rural practices make value-based care work. So Equality partners with over 800 Medicaid serving practices nationally. And right here in Louisiana, we already support more than 50 partner practices serving more than 75,000 attributed Medicaid patients. And that matters because we're not coming at this from conceptual level or theoretical level, or from a pilot idea. We already have folks on the ground in Louisiana, and we understand the realities of serving folks in rural parishes, and the rural practices that you all work in and work out of. So what we bring at our core is practical infrastructure, and we avoid the, pushing more burden because the work is hard enough. So our model combines Care and Power, which is our proprietary population health platform, with a hands-on practice coaching approach, along with care coordination, community health workers, outreach support, complex care management support, and activity-based payments that are closely, tightly aligned with quality and HEDIS work and tightly aligned with evidence-based medicine. So, in other words, we're not just a company that puts dashboards together and tells you to do more work. We are really helping to convert data into actionable insights and to really help catalyze and make sustainable, true whole person care. So for Louisiana RHTP, our fit is fairly straightforward. We help turn rural VBC funding into repeatable, sustainable workflows. So closing care gaps, engaging hard to reach patients, supporting chronic care management, evidence-based care, improving quality, reducing avoidable ED visits and admissions and readmissions, as you heard Eli mention. We are really super powered to help support and drive a lot of that work. And what we do, and we do it in a practice-friendly manner. We respect native workflows, and we really help practices, and we indemnify folks of the downside risk. So we're providing financial incentives that are activity-based, and we're doing that quarterly to make rural practices more sustainable and more successful. So we believe rural providers really don't need another short-term pilot. So we really focus on sustainability and operational and field-based sustainability. So if you're a rural clinic, rural practice, if you're serving folks in rural parishes, certainly give us a ring. We welcome the conversation, and we want to support the communities that you all are serving.
All right, thank you so much. So next we will move to Josh Lowentritt presenting on behalf of Generated Health.
All right. Hey, great to see you all today. Hey, I'm Josh Lowentritt. I'm a lifelong Louisiana resident, Louisiana physician, and I'm Chief Medical Officer for Generated Health. Like many of you, I've spent my career caring for folks in communities where staffing is limited, resources are stretched. Too many of these patients are falling through the cracks. The reality is that patient care doesn't stop when the patient leaves the clinic, but our ability to impact the care does. That is why at Generate Health, we built Florence. We call Florence the care team multiplier. Florence is a clinically validated, automated care management platform that communicates with patients through simple SMS text messaging. We use evidence-based clinical protocols, such as we pull from the ADA for diabetes. This helps guide Florence's messages to patients. We use AI safely to interpret the messages that the patient sends back, and we alert your care team whenever human intervention is needed. If you think about it, and the graphic, if you think about it as a care loop, your clinicians are setting the plan, what diseases need to be addressed. Florence will help execute that plan between visits through ongoing conversations with your patients. And when Florence identifies someone who needs clinical attention, Florence will escalate it right back to your care team. We're not here to replace clinical staff. We're here to supplement them, to take on the routine work, like literally whispering in the patient's ear through their text message, through their phone, between visits. The result is continuous support between visits without creating additional work for your staff. We're prioritizing the work for your staff. Because we work through simple SMS, there's no app to download, no broadband. You don't need Starlink with Elon. No digital literacy barrier is very effective in accessing rural and underserved communities. And we're deployed across rural communities in the U.S. We help with diabetes, blood pressure control, reduce unavoidable admissions, hospitalizations. we're really good at increasing patient engagement. Um, in fact, I see this with my own patients here in Louisiana. I've had multiple of my CKD patients on the program, and I've had patients come in literally say, "Hey, where's Flo?" Because they want to thank Flo, the person, the software, and it's that's an interesting conversation. To them, Florence seems like a trusted member of the care team, someone who's checking in on them, answering questions, providing education, and helping them stay on track. That's the experience that we meant to create when we built Florence. As Louisiana and you are investing in rural transformation, we believe technology like this should help strengthen clinicians. We help organizations around the country reach thousands of patients, identify who needs support. Hey, we're live in Louisiana. We love the opportunity to help. Thanks so much.
All right, thank you so much, Dr. Lowentritt. Just a reminder for our attendees, if you have any questions for any of our presenters, please feel free to pop those into the Q&A box, and then we will answer all of those at the end of our presentations today. So next up, we will have Yvette Delon from LPCACO.
Thank you, Danae. I appreciate the opportunity to join in this forum. And I just would like, before I get started with us, I'd like to say that Azara and Bamboo and Wakely and Equality Health, we've had the pleasure as an organization to work closely with. And we would give wonderful testimonials and referrals to those organizations and appreciate the opportunity for exposure to partner with other vendors that can help us move the needle with rural care. Our network, we have ACO in our name, but it's only a fraction of what we do. Satsuma Health Network is going to be our new DBA, which is a nod to the Satsumas, which give us so much joy and smiles. But our organization, we are a care delivery and payment innovation organization, not just an ACO. ACOs are formed to administer directly with regulatory bodies specific programs such as MSSP, where our network, for over 6 years, we've been in the top 5 to 10% in performance nationwide. This type of performance is what type of network criteria clinics would like to look at to join so that they can be in a cost sharing structure. Some of the small rural clinics across Louisiana, and I know this firsthand being raised in Concordia Parish, they just don't simply have the staff or the capabilities. And so when you join a network like ours, you're able to have those shared costs and you're able to have the expertise from small to large and those that have struggled through some of the growing pains that new rural clinics coming into value-based care will experience and need some helping hands. And our network can offer that. But we also want to say that we're an open door. We're a partner because we want to see Louisiana go from being worst to first as far as the quality of care. And anybody, we have an open door and we are willing to help whether you join our network or not. We have a wonderful tech stack that offers the data analysis that was described by Eli at the opening of this meeting. And some of those tech partners you get the privilege of being exposed to today, such as Azara and Bamboo. And then, of course, we have Wakely from Actuarial that does those pretty color-coded charts like Eli spoke to, where we can really focus in on cost. Statewide, we are a network of primary care serving rural patients, and we're locally owned by 25 nonprofit clinic owners with a mission that is very much aligned with the state, taking care of patients one patient at a time, with 17 value-based incentive programs currently under administration, and we've had award-winning payment models as well. We look forward to help anyone out, anywhere, anytime.
All right, thank you so much, Yvette. So we will now move to Van Lee from the Louisiana Public Health Institute. Van, you have the floor.
Hi, everybody. Thanks so much. My name is Van Lee. I'm the Associate Director of PELEX. We're a health information exchange based out of the Louisiana Public Health Institute, based in New Orleans. We're at HIE based in, or that started 10 years ago, supporting FQHCs, community health centers, and behavioral health organizations make retrieving real-time data from health systems a lot easier. We support real-time access for care coordination follow-up and chronic disease interventions, and really work closely with care teams at our member organizations to support them in developing workflows and strategies that fit into their day-to-day and also fit in with their existing partners and vendors. We are at a vendor agnostic HIE, so we're willing to work with any current solutions that you have currently to either visualize your data or to perform the follow-up functions on a day-to-day while providing a more complete picture through the data infrastructure that we support as a health information exchange. Right, so you can really think of us as providing the plumbing for health data. So providing and building that secure infrastructure for data exchange between disparate facilities and offices where patients are receiving care at multiple practices. And while doing that, providing a secure method of data exchange, applying HIPAA practices, and by being that pre-existing infrastructure to support that data exchange, we're offering a sustainable path forward for not just your organization, but also your partners and vendors, and many of the other organizations here on this call we've worked with as well to support care coordination at the provider level and supporting that patient health improvement along the way. So, for example, we work with LDH in receiving Medicaid attribution data, and we're marrying that with encounter information so then providers can see where their patients are going and also what insurance coverage they have. We're working with rural providers in St. Landry and Morehouse parishes to implement care coordination products and services. One, namely, is the Rural Health Care Coordination Network in St. Landry Parish. It's a partnership with PHUs and with LRHA there, and working with value-based care providers and data platforms such as Equality Health and Azara to support analysis and care closure gaps or care gap closures by providing encounter data through our HIE. On a broader note, we're looking to not replace or recreate an existing solution that you're using, but really augmenting the partnerships and solutions that you're currently using. And so we really hope that we can build a better data system that improves access, transparency, and security, and producing those system savings and efficiencies for better health improvement outcomes in the state of Louisiana. So looking forward to working with some of you in the near future. And thank you so much.
All right. Thank you so much, Van. So next up, we have Jim Lancaster from Main Street Rural Health.
Danae, thanks so much. And good afternoon, everyone. It's so nice to see you all today. Honored to be here. And, it was great to meet so many of you in Natchitoches a couple of weeks ago. We're so excited about supporting Louisiana. At Main Street, it's a relatively new state for us, but we have some incredible partners that many of whom we got to see a couple of weeks ago. We're one of the nation's largest Medicare ACOs. In only a few years, we've grown to over 250,000 patients across the nation. And as of January, we'll have 30 states active in our partnerships focused on rural America. We are about the Bernices over the Bostons, if you will. And, we love our partners in Louisiana. We're in Richardson in Rayville and LaSalle and Gina. And Monday, we have a kickoff with Savoie and Mamou and with that team, and excited to support them as well. Our support of primary care across small towns in America only started a few years ago, as I mentioned, but we really feel like it is a new chapter in value-based care for America, which is why it's resonated so well. We know that rural America has been underserved, under-resourced, underfunded in the terms of primary care, along with providers. So we're really excited. Since we rolled out a few years ago, I've been with the company now over 4 years, and one of the things we've always talked about, or I've always talked about in small towns in Kentucky and Alabama and Mississippi and kind of across the nation, is our 3 R's. And I think about those 3 R's that have been a new paradigm for us. I think about resources. We're really about people over portals. You see the picture there. That's actually Christy. Christy's one of our navigators. We have over 500 navigators working across America, full-time salaried people that we've hired that work in small towns across America where they live, supporting primary care right along the team. That's actually at Reeves Medical Center. And that's kind of one of the things that differentiates us. In primary care, it was the kind of help I needed and never had as an independent primary care doc for several decades, and why I joined the company. And we think that's most of our secret sauce. The second is revenue. Value-based care revenue has always been unpredictable. I call it maybe money. The work's always been guaranteed, but the money's a maybe. So we have changed that paradigm to guaranteed, predictable revenue. Every partner in our ACO gets revenue every single year because we know that's what primary care needs across America. And the third is relationships. We're really, we don't consider ourselves, quote, a vendor. We consider ourselves a partner. I think it's got my contact information on there. That's my cell phone. We would love to communicate with you all. We don't really like virtual visits, although we're honored to be here today. We'd love to have a conversation in your hometown in Louisiana as the next chapter, and come see y'all and learn more about the hometown and see if we can serve and support you like we have so many others across the nation. So thank y'all so much. Appreciate your work.
All right, thank you so much, Jim. So next up will be Dana Hewitt from Target Health.
Hi, good afternoon, everybody, and thanks for having us. My name is Dana Hewitt. I'm one of the owners and founders of Target Health, and we're a proven value-based care management company providing a concierge approach to all things value-based care. And we're right here in Louisiana. We've been in business for over 10 years, and our office is in Mandeville, Louisiana. We see ourselves as a true enabler company, helping rural health clinics learn value-based care, understanding all the arrangements through the MCOs and all the quality programs that they offer. We really teach how to be successful through practice transformation, patient engagement, analyzing data, coding, and documentation. Our team is comprised of RNs, LPNs, and medical assistants and data analysts. We come on site to your practice and do a true assessment and work hand in hand with your clinic staff to help them understand coding and documentation, to really hone in on the patients that matter, right? To perform patient engagement, to get those patients back to your clinics and to engage with them. As we do that and we lay that foundation of value-based care management in your practice, we then start to help you track and trend your quality performance and your financial incentives month over month and year over year. We've had the opportunity over the last 2 years to work with about 20 rural health clinics across the state, and we've been able to really drive quality and financial performance success. Since we've been doing it now a few years, we actually have a proven track record in our rural health clinics showing their quality performance improving year over year in diabetes, controlling hypertension, keeping patients out of the hospital. Also helping our rural health clinics use their EHR effectively, right? With F codes and specific codes that the payers need so you can prove the true quality that you're giving and the control of your patients and chronic conditions. We have a nurse call center here on site at the office. Specific nurse teams call for our specific rural health clinics and become a true extension of the care team. So when our nurses make outreach, they're calling your patients and acting like an extension of your team. We're payer portal experts. We know where the data is, we know where the quality measures are, and finding those patients that matter and associated with VBC. And we are here to help with the NOFO process and the application process. We're happy to help, and we see ourselves as a true enabler company for your success in value-based care. Thank you.
All right, thank you so much, Dana. So up next is Kenneth Adams from TrueBridge.
Hey, Danae. Thank you so much. Can you hear me okay?
Yes, you are good.
All right. Well, guys, first and foremost, thank you for all that you guys do on the front lines to serve the communities. I know it's difficult work. I've been in this business for a while, so much appreciated. I know that you guys all wear multiple hats, as do I for TrueBridge. One of those hats is the program manager for RHTP. If you don't know about TrueBridge, we have been providing EHR and end-to-end RCM capabilities to rural healthcare for over 40 years, including a lot of critical access hospitals and RHCs in Louisiana. And I really think that value-based care in rural Louisiana lives and dies on two things that happen before a claim is ever even filed. It's about getting the patients in the door, either physically or virtually, for their AWVs, for their CCM encounters and the like, then ensuring that they have coverage and capturing their care and risk accurately in accordance with payer contracts. That's where we focus end to end in our technology and services stack. To Eli's point earlier, our mission is really to support the financial sustainability of APMs longer term that align financial incentives with the overall quality of the care that you guys are providing every day. I'm going to break down rapidly our capabilities into two buckets. First, it's about access for us. We handle patient cohort outreach that's driven by our patient population health analytics. We handle appointment scheduling and a full patient access stack, which is becoming more important with OBBBA. So that includes insurance discovery, presumptive charity, concierge, Medicaid enrollment, and then financial aid and medical mutual aid workflows. So in a state like Louisiana that is heavily Medicaid dependent with Medicaid tightening, that does two things at once. It gets rural patients enrolled and connected to care, and it protects the provider's revenue and margins. So access and sustainability in the same motion, exactly what this type of funding is about. So that's access. Second is about capture down the workflow stream. Our EHR workflows help run CCM programs. They surface care gaps, capture quality measures and SDOH at the point of care in the workflow of the care team, the current workflow. Then our HFMA peer-reviewed coding services and RAF HCC aware encoder make sure that the picture is coded completely and defensively. Because in a risk contract, the accuracy of your risk score and quality capture is your revenue. And we carry that claim through to payment to ensure that you are getting paid accurately for the services that you are providing based on the payer contracts that you have. So we cover every touch point within the encounter from patient outreach all the way to final bill. It's not a hodgepodge of point solutions, it's one integrated solution, and that maps directly to Louisiana's plan. So we're all about getting the patients in the door, get them covered, capture their care accurately, and then code and bill with full confidence end to end, the very foundation that every value-based contract is built on. And I'm at time. Thank you guys for your time today. Look forward to hearing from some of you guys.
All right. Thank you so much, Kenneth. So last but not least, we have Hunter Showeiler from Wakely.
Thank you. Great to be here, and thanks for having me at this event today. Wanted to just tell everybody a little bit about Wakely Consulting Group. I am a director at Wakely, and I lead our national value-based payment practice. At our core, we are a national healthcare actuarial and strategic consulting firm. We focus solely on healthcare. And within our VBP practice, we focus with organizations with their actuarial analytics and their strategic outlook on their VBP journeys. We support states, health plans, and providers of all shapes and sizes and maturity. We help them with understanding their experience in value-based payment arrangements, forecasting their performance, and really getting down to the root of where their opportunities and the magnitude of those opportunities lie, and then using experts such as myself with prior VBP experience operating VBP entities to really get at the tactical and strategical nature that needs to be put forth in order to succeed in these models. In relation to RHTP, we can support you all in a couple of different ways. For those that are considering the lane 2 option and looking at an alternative payment model, I think our value is really in supporting you in transitioning into that sustainability pathway with potential payer partners. As you think about running your pilot, evaluating where you're performing within the pilot, and then looking at strategic options to make those different models sustainable over time. Within our group, we have over 70 credentialed actuaries, along with other experts in value-based payment structure and design, as well as operations and strategy and finance. And at the core of things, we really look to be a trusted advisor in your VBP journey. We want you to be our number one call when you have a question or a challenge that you're trying to address. And we have deep roots in Louisiana, working with health plans as well as providers, LPCACO being one of them, working with health systems as well as small independent rural providers and FQHCs. Thank you all for the time today.
All right, thank you so much, Hunter. And thank you to all of our presenters today. I appreciate you guys being right on time so that we can get through a lot of content really quickly. So I do appreciate that. So we will now move into our Q&A portion. So we do have some questions queued up in the chat. I think these first few ones are for Eli. So if you want to kind of get prepared, we'll go through these questions. Please feel free to continue to enter questions into the Q&A box as we answer the ones that are already here. So the first question we have here is it possible to monetize the BSBC, the Blue Cross Blue Shield settlement with our BSBC's settlement with select facilities who claimed?
I'm not sure I know enough to answer that question.
Do you know who we might be able to send that question to?
I think the NOFO has a place for questions and answers. I would recommend submitting it there. We're collecting all of those questions to get the right person to review and answer those.
Okay, so this question is a follow-up question on the incentive payments. Can we assume that we can request funding for allowable out-of-pocket costs plus a separate incentive payment? Assuming we include an incentive payment, should we assume an expected outcome and project the total incentive payments that may be requested as part of our total application? And then there's another question in the same thing, but I'll let you answer that first before I read the next part.
Yeah, so as I mentioned, we have infrastructure investments that could be reimbursement of specific items like staffing, software, etc. So things that will enable you to do, value-based care or alternative payment models. And then that is going to be a limited one-time investment. And then the second portion of that is progressing towards improving quality, reducing total cost of care. And that could be either ILOS or total cost of care plus quality. So you can definitely combine those together. I think we're looking for comprehensive proposals that have sustainability in mind as well. So this could be 1 year proposal with extensions of up to 3 years. And if you have specific projects in mind, you do want to follow up. I pasted the link to the funding opportunities page on our website. There's a lot of guidance on there on how you might want to think about structuring those proposals.
All right. And the last part of this question is, can you walk through how to present our proposed incentive payments in this or in a future webinar? Specifically, what elements should be in the budget narrative and how to tie that into the APM budget template?
Yes, happy to do that. We have monthly webinars that are scheduled, and you're free to reach out to Ashley on our team or Rural Health Transformation at la.gov, which is our office email that is being monitored. So if you would like to reach out to us and kind of explain a little bit more what information you're looking for, we can definitely schedule something to address that specific need.
All right, thank you. Louisiana Act 629 requires the state Medicaid program to cover dental procedures when medically necessary to clear an enrollee for other covered medical services such as cancer care or heart surgery due to untreated oral infections and inflammation. How will the gap analysis and care coordination vendors work to automate care coordination, support for medical dental interoperability to advance this care need?
I think this is a vendor question, right?
I believe so. Yeah. So anyone who is identifying themselves as a care coordination vendor, if you want to maybe raise your hand, might be the easiest way if we have multiple people who want to answer this question.
Danae, can you repeat the question? I think there were parts of it that I may have the commentary,
Yeah.
but
So it's talking about coverage for dental procedures when they're medically necessary to clear a patient for certain medical procedures. So how will the care coordination vendors work to automate care coordination to advance this care need? The medical dental interoperability.
Yeah, I can speak to this. We do a lot of uh, largely oral sort of body care, and we believe in whole person care. So uh, to make it short, we really guide that particular patient across the continuum. So insofar that there's an oral need, oral surgery need, and or say a cardiac need that requires oral clearance, we have folks that help navigate what can be a complex process, understand where that oral medical home ought to be, who that dentist of record is, and if there is not a connection, making that connection and making sure that the various providers, both on the clinical side and then the service and community-based organization, are all talking to each other to be able to get that patient across the finish line.
Danae, do you mind if I add something?
Go ahead.
And I don't know if this is going to answer the question, but what we're doing specifically now with our rural health clinics is we get them to run reports out of their EHR to show patients that are maybe only seeing dental or maybe only seeing BH and only seeing the medical provider, the physical provider. And we try and merge those lists together, right, to take a holistic approach to the patient. So if they are attributed to the PCP, but never coming to the PCP and only having dental or BH, how do we bring that patient back in so we can take care of the whole patient? And so, of course, then as we're seeing them for their diabetes or their hypertension or just their annual wellness visit, you're easily able to see there's a BH need or there's a dental cleaning or there's a dental issue, then we're going to bring them in to take care of all of that and address it at that time.
All right. Thanks so much, Dana. If I think we can have time for one more person to answer this if you'd like to, and then we'll move on to the next question. If anybody wants to jump in. All right, hearing none, we will move to the next question. So the next question is for Wakely. It says, do you represent MCOs and do you have access to the premiums and TCOC data sets by rate cell for various MCOs?
We do not represent any Medicaid MCOs in the state of Louisiana that I am aware of. We do support the Louisiana Medicaid Health Plan Association. Um, we do not have access to the individual rate cell level premiums at each of the plans. Um, what we do have access to is a TMAssist data set from CMS that has somewhat lagged, but it has the full encounter data for all of the Medicaid populations in every state that we can analyze utilization patterns for Medicaid patients within different rate cells.
All right. And then are the applications to work with vendors to be submitted with them specifically in mind, or just phrased as we'll be partnering with a vendor? Eli, I think that might be a question for you.
I would recommend mentioning specific vendors and discussing with vendors their availability and capability statement, including whether they have the specific relationships, access to data, etc. And then I would also mention that you can include multiple vendors. It doesn't have to be just one.
All right, thanks. Yvette, I see you raised your hand.
Thank you, Danae. I just wanted to add on to Hunter's response with Wakely on the question about total cost of care and the rate sales, if I may. I can say that organizationally, our network, we review the state fiscal year rate report that's produced by LDH for Medicaid, and we do that hand in glove with Wakely on an annual basis. It helps us develop payment models and get to a better understanding of the product classes, and we look at that at zip code and at parish level. So I just wanted to share that there are alternative options to reviewing that type of data that the question was pertaining to.
Okay, thanks, Yvette. So those are all the questions in the Q&A box right now. I do see Eli put the link to the NOFO he mentioned in there, as well as the email address for general rural health transformation questions, and the direct link to the NOFO. So all of that information is in the chat box for you. So we'll just give another minute or two for folks. If you have other questions, feel free to put them into the Q&A box. We do have a little bit of time left to get those questions answered. While you have your rural health transformation team here on the call, if you have any burning questions, now's the opportunity. And then while we're waiting on that, Eli or Julie or Ashley, if any of you guys have any additional comments you'd like to make for our providers around the Rural Health Transformation Program, or any of the NOFOs that are out, or the surveys that you're still looking for responses on, anything like that, feel free to share while we wait for additional questions.
I'll just jump in and say thanks everybody for, for joining today. Our goal really is to try to help make sure that all of these funding applications and funding opportunities that we have that might require our rural healthcare providers, to find partners, that we're just kind of helping you all to understand. As Danae said at the beginning, none of us are endorsing any particular, method or vendor or folks to partner with, but we do want to make sure that folks know what's available, what's out there, that may be able to help you with your application for funding for the activities. This one specifically for alternative payment models. So we hope that this was helpful. Would love to hear feedback about how we can help bring more of this information to you guys in the future, to be able to help make that connection. So thanks, thanks for the rural healthcare providers for participating, for the vendors that were on sharing information about what you have. And so just want to share those thanks. Thanks, Janae.
Thanks, Julie. So we do have a question for Target Health. Do you work with all payers or only a specific set of payers?
We work with all payers, so all of the Medicaid organizations, Medicare Advantage programs in Louisiana, as well as Blue Cross Blue Shield commercial.
All right, thank you so much.
And I did paste a link to the survey on rural provider value-based care and alternative payment model readiness survey. It's also available on our homepage.
All right, thank you so much. And I do recommend folks continue to check that homepage for the Rural Health Transformation Program. It's updated pretty frequently. There's a ton of information and links and surveys, and all the NOFOs are on there. So if you haven't been to that website yet, please do go there. All of the information is there for you. We're also, as LRHA, trying to send that information out in our newsletters and things like that to try to help keep you guys up to date, because I know it's a lot to keep up with. It's moving very, very fast. So hopefully we can try to keep you guys informed, but I do recommend you try to check the website as frequently as you are able to for updates. All right, any final comments? I see no more questions. So Eli, any final comments from you before I wrap up our session for today?
No, thank you for organizing this and hoping to see a lot of great proposals for this notice of funding opportunity.
All right, thank you so much. So thanks so much, everyone, for joining us today. As a reminder, when you exit the session, you will get a survey that will open. Please do complete that. It's very brief. A recording of the event along with the slides and our vendor database will be available on our website within the next couple of days. We should be able to get that up by the end of the week. And as always, please feel free to reach out to us at LRHA if we can be of any assistance to you. And thank you so much and have a wonderful afternoon.
Thank you.